Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well.
Caring Well. Welcome to Caring Well.
Welcome to Caring Well.
Welcome to Caring Well, Middleton Pediatrics podcast, where we have discussions and conversations about medical issues that help you care well for your child. Today, we have one of those conversations with Dr. Joshua Yang. He's a pediatric endocrinologist at Arnold Palmer Hospital. Wide range of things that we discuss. I think many things you're going to find really interesting and helpful as you care for your child. So let's go to that conversation. Dr. Josh Yang, welcome to Caring Well. We're so excited to have you.
Thanks for having me.
Yeah, this is going to be fun. Definitely a lot of different topics that we'll get into. But before we do any of that, would love for our listeners, our families, to get to know you a little bit. And so your journey into pediatric endocrinology and how you ended up to where you are today.
I went to med school thinking I want to do ophthalmology, but ended up doing pediatrics just because, at least to me, I had really had a hard time figuring out if adults really were sick or they're just having a bad day. And kids would rather be out playing. So, if they're sick, there's something wrong. So I took a liking to pediatrics and did a residency. I was a resident here.
And medical school for you was Texas.
Had
you grown up in Texas?
Tech. No, I grew up in California.
Okay.
So I grew up in Southern California, and my parents actually ended up moving to Texas right when I was in college. So I ended up going there for medical school.
Okay.
Yeah. And it turned out to be, it was great because I was there for 4 years and ended up coming here for residency. I'd actually interviewed in a lot of different places. I did college in the Midwest. So I figured, well, maybe I'd go back there. So it was interviewing in Chicago. It was minus 10 degrees out there, December. The following week I came to Florida. It was 70 degrees out here.
Yeah, that's a good sell.
So ended up in Orlando here at Arnold Palmer. And then after residency, I ended up doing endocrinology because I've always been a numbers guy and pathways, organic chemistry. So it really made sense. I just liked the pathways and ended up, as you know, endocrine, there's a number for everything. There's a lab that we order. So we're interpreting numbers all the time. And just how my brain works, that's just, it just suited me.
How do you describe endocrinology or pediatric endocrinology to someone that's not in medicine? Do you have a simple way of telling someone what you do?
It's hormone problems that children.
That's the general
That's
term
the general
you
thing
use.
is hormone disorders.
Okay.
So it's a little bit different than the adult hormone problems that, or hormone problems that adults have. We still see diabetes, but as you know, we see mostly type 1 diabetes, whereas adults are type 2. But we deal with growth, puberty. We do see our fair share of thyroid and diabetes.
All right, well, why don't we jump right into diabetes? That's probably the condition that most people are at least somewhat familiar with. As a way to start, what would be sort of a typical picture by which a parent might suspect or get concerned about the possibility of diabetes?
The presentation of diabetes typically is child starts drinking a lot, starts peeing a lot, especially if it occurs at night. And this happens because your blood sugar starts increasing. And if it gets above a certain level, you start spilling glucose in the urine, and then it pulls all that water out. So these kids end up having, using the bathroom all the time, more frequently than usual, and then they get thirsty. So then they start drinking all the time. Sometimes in the summers here in Florida, it's difficult to really ascertain if there is that polyuria and polydipsia going on. You may think, oh, they're just hot, they're just drinking water all the time. But if it happens overnight, that's typically a sign that something else is going on.
Is there something about variations throughout the day with blood sugar levels that makes it, or it's just night? Usually you don't have that issue at all.
Yeah, usually don't have that issue at night, especially in a child who's already potty trained.
Right.
And then all of a sudden they're waking up in the middle of the night to use the bathroom, to drink water, or start bedwetting. Then that's really indicating something.
It's a red flag there.
On. Yes.
Okay. It seems, and maybe this isn't true, so maybe the first question is this even true, that the incidence of type 1 diabetes is increasing slightly?
It is.
Why is that, or what are some of the thoughts for that?
Yeah, so we know the incident rate is increasing by 3 to 5% in kids every single year. We think it's likely due to, we know it's an autoimmune disorder. So what happens with type 1 diabetes, you have a genetic setup. You have genetic markers that put you at risk for an autoimmune condition. But then something in the environment has to trigger that attack, where all of a sudden your own immune system's attacking your own cells. And we think it could be a virus. It could be something in the environment that we just really don't know. Some people have said vitamin D deficiency, diet, but I think we're seeing an increase incidence of autoimmune disorders across the board. So I think because the genetic setup is always there, it's something in the environment that is triggering the start of the immune process.
It probably is worthwhile to, because some of the things we'll get into later, we'll talk about some specific aspects of diabetes. And so autoimmune, meaning someone's own immune system is attacking the pancreas and specific cells in the pancreas, these beta cells that secrete insulin. And so the result of that is the diminished amount production of insulin.
Yeah.
And so your own immune system attacking your own pancreas and therefore inhibiting its ability to produce insulin. Is that a pretty good nutshell?
That
way
is.
to describe it?
Yep.
Okay. So, and maybe this is even impossible to know, is it of those that test with a genetic possibility or tendency, propensity towards developing diabetes, how many of those what percentage of those would go on to develop?
Yeah. So the genetic risk score that we have looks at 70 locations in the entire genome. And if you have certain variants or what we used to call mutations in these areas, it increases your risk of developing type 1 diabetes. Now, even if your genetic risk score is positive, it means you probably have a 10 to 20% chance of developing diabetes.
So the vast majority will not.
Correct.
Okay.
Now, if we can identify that you are a high-risk individual, we have ways of looking at antibody markers to diagnose type 1 diabetes much earlier on than we traditionally would diagnose kids when they come in drinking a lot and peeing a lot.
Yeah, I want to come back to that because that's obviously one of the exciting things that you're involved with. Is there any way to know, talking about this 3 to 5% increase, is there any way to know if those carrying the genetic propensity is also increasing, or is it just higher percentage of those that have it are converting?
Yeah, I think it's people who are converting.
Okay.
Because I think the genes, the genetic setup is there.
Okay.
And it's always been there. Although one can make an argument, of course, perhaps there are some changes to that where you have an increase, but that's an interesting question, I think.
Let's just talk about current management and prognosis. And maybe one way to do it would be if you can pick whatever timeline you want, but pick, say 10 years ago, give us a picture of what diabetes management looked like and what it looks like today.
I can even go 20 years.
Yeah, whatever makes the point.
Since even finishing fellowship in 2006 until now, at that time, we were using much older insulins. And in the late 90s, early 2000s, you started seeing newer insulins coming out, new insulin analogs that allowed the insulin to be given in a more physiologic manner. But even 20 years ago, we were using old NPH and regular insulin, giving it twice a day. And if you were on that NPH regular insulin regimen, you actually had to eat breakfast, lunch, and dinner at the exact same time every single day. And you had to really eat the same amount of carbs per meal. Otherwise, your blood sugars would either go very high or very low.
Yeah, very rigid.
Yeah, very rigid. And the multiple dose injection method allowed for more freedom and flexibility. And now you can eat anytime you want. You just have to figure out how many carbs you're having, and you give insulin to cover that. And, we moved to more of these faster, fast-acting insulins, longer, long-acting insulins. And then eventually now the technology has really boomed in the last, I would say, 10, 15 years as well. You have to check your blood sugars, right? That's one thing to monitor diabetes. You have to monitor blood sugars. And traditionally, we would have to poke your finger multiple times a day.
So yeah, maybe a pause, because what you're describing it really is remarkable what has to be done externally to try to replace this remarkable system internal when it goes awry. So prior to the development of diabetes, as blood sugars rise and insulin increases, it's this fine tune. I do this because I always think of endocrine as a series of knobs.
Yeah.
It's really this dial up and down. And so the inability to regulate blood sugar because of the lack of insulin. And so what you're saying is you've got to take this system somewhat external. You've got to monitor the blood sugars, and then you've got to do the job of the pancreas.
Yes.
And that's, again, it's a knob.
Yeah.
More insulin, less insulin.
Right. If you crank it up too high, then your blood sugars go low. If you're giving too much insulin, if you
Which
don't
is
eat
incredibly
enough,
dangerous.
Exactly.
Yeah.
And if you're not giving enough, then your blood sugars run high, and then you have long-term complications with high blood sugars later
and
on.
Just hit a couple of those real quick. The reason it is so imperative to, again, I keep doing this, fine-tunely manage this is because the absence of doing that results in long-term what?
Problems with your eyes, kidneys, and nerves. Instead of having to poke your fingers now, you can wear a continuous glucose monitor. And it's a little device you wear. It lasts, I think, over about 7 to 10 days, and it can monitor your blood sugars in real time. So now you don't have to poke your finger anymore. And then now there's insulin pumps. If you're on insulin shots, once again, if you take 5 or 6 injections a day, once again, the numbers add up per year. And now if you were an insulin pump, you just have to change the site every 2 to 3 days, and then you can give insulin through the pump.
Is there any way to give a picture of what you think it might look like 10 years from now?
Yeah, it would be great to have an automated insulin delivery system, or what we call just artificial pancreas. Right? So something that can allow you to manage diabetes without thinking about it. Right now, if you look at how many times the average person with type 1 diabetes thinks about diabetes, it's probably around 180 medical decision-making decisions per day. And that's a lot, because every time you eat, you got to figure out how many carbs you're having to give the right amount of insulin. If you're exercising, you have to make sure you're not running low. So hopefully, from a technology standpoint, maybe in a decade or so, you can wear a continuous glucose monitor and a pump, and they can talk to each other.
It's amazing. All right, shift gears a little bit to, so that's once someone's been diagnosed, but going upstream, the idea of screening patients who may have it and don't know it, or may have a risk for developing it, and then the ability to intervene when that is seen. Where are we with that?
So that's a hot topic right now in type 1 diabetes. And as you know, the majority of patients that we diagnose are already symptomatic with high blood sugars. They come in drinking a lot, peeing a lot. You check their blood sugar, it's sky high. We know that process actually has been, it started perhaps years, and in some adolescents, adults, it may be a decade or so before you actually become symptomatic. And it's that process where your immune system's attacking your beta cells. So everyone starts out with 100% beta cell mass, or healthy beta cells. And over time, it starts diminishing. And then eventually, if you lose enough beta cell mass, then you become symptomatic. So we're now trying to identify patients much earlier in that process. And if you can identify it early enough, we're hoping to have immunotherapies or disease-modifying therapies that could delay the onset of needing insulin. And there's one that's already been FDA approved now that we are using if we can identify these specific patients.
Trying to make it in a way that's understandable to those outside of endocrinology. You've got genetic propensities, but again, most of those people won't ever develop diabetes. And then you've got maybe the next step would be you have some of these autoantibodies, these antibodies that you can see that the body is starting to attack the pancreas,
Correct.
But still no symptoms.
Correct, no symptoms.
And then it can progress to blood sugar changes, but still no symptoms.
Correct.
And then it can become symptomatic.
Correct, yes.
And pretty much to date, our only way of getting any insight was when it became symptomatic. But now you say we have a therapy that we can, it's been approved.
Yes. So now we're trying to identify these patients, as you said, upstream. And these are patients who have the autoantibodies. So think of autoantibodies as just markers of the autoimmune process that's going on. Before you become symptomatic, remember now that you continue to lose beta cell mass, and then your blood sugars starts to increase. And if it's starting to become abnormal, that's when we can give this disease-modifying therapy.
And that's what's technically called stage 2.
Correct.
Okay.
Stage 2.
So stage 1 is you've got antibodies, but nothing else.
Yes.
Stage 2, you've got antibodies and some blood sugar changes.
Yes.
Stage 3 being symptomatic. And you say there's an intervention at stage 2.
At stage 2.
Okay.
To delay the onset of stage 3.
Okay.
And it is, it's a 14-day daily infusion. Now it's just a one-course therapy.
One course over 14 days.
Okay. Yeah. And then it does take about 30 minutes each day to do the infusion. And that single 14-day course can delay the onset of stage 3 diabetes or needing insulin by approximately 3 years.
3 years.
About 3 years. Now, you got to remember, we're still in the beginning stages of disease-modifying therapy. And this is the only one that's been approved by the FDA. So eventually, if we have other agents that come out, or perhaps repeating the infusions, could we push stage 3 further and further away? And could you, right now, if it's 3 years, potentially could it be 10 years, 15 years? Could you prevent diabetes from the front end?
And so where that translates into practice is potentially checking for those antibodies, the presence of those autoantibodies. And at least currently, that is being recommended to be done in first-degree relatives?
Yes, first-degree relatives. And also now, if you have a personal history of an autoimmune condition. So what I've been doing is also checking patients who I see for Hashimoto's thyroiditis or Graves' disease. Because if you have one autoimmune condition, you have a much higher risk of developing another autoimmune condition.
Any idea on insurance paying for these
Yeah.
tests?
Yeah. So as long as you code it correctly, it is getting paid for. If you go to the commercial lab. Now, there are some research studies out there that will test for free. And TrialNet is something we've used for quite a while. And they test for patients with first-degree relatives, second-degree relatives of diabetes. But there are other places you can go that will offer free testing, even without family history. So more of a general population screening.
Let's go back to stage 1. You have these 2 out of 3, at least 2 of 3 antibodies,
least 2, yes.
But your blood sugars are fine. How often are you rechecking that to see if they've moved into stage 2?
Yeah. Right now, if you look at the and there's natural history birth cohort studies that will say, if you are in stage 1, the chance you will become insulin dependent over the next 5 years is around 44%. 10 years is about 70%. And then once again, over your lifetime, it is close to 100%.
So that's a great important point of distinction. If you have not the genetic propensity, but if you have the 2 of the 3 autoantibodies, essentially 100% at some point
in your lifetime. So you're not really looking at that now as a risk factor, but you have type 1 diabetes.
Yeah.
If you just have the autoantibodies.
So from your perspective, stage 1, you have it.
You have it.
Okay. All right. What about you have a first-degree relative and your autoantibodies are negative?
Yes.
How frequently do you repeat those?
Yeah. If you're an adult, you test at age 18 and you're negative, the thought right now is you're going to be okay, that you're not going to seroconvert after that time. However, so what's actually really interesting is the autoantibodies can be present as early as 9 months. And the peak is between 9 months to 2 years. So a lot of patients actually will already have the autoantibodies present, and then they develop symptomatic or stage 3 type 1 diabetes much later on in life. So the recommendation in children is to check at age 2. And then obviously there are going to be seroconversion. So there are going to be patients who are negative that will convert over to having at some point. The next time point to check is probably around age 5 to 6.
Anything else you'd say about diabetes?
I'd briefly mention perhaps we can delay, prevent, or cure diabetes from the front end. Well, there is research going on trying to cure diabetes from the back end. now. So once you're in stage 3, the majority of your beta cell mass or function is already gone. So how do you cure diabetes? You got to replace,
Beta cells.
do cell replacement, correct? And they are looking at that.
This is like a transplant on a cellular level.
Mm-hmm. Yeah, and now we're able to use stem cells to
Okay.
create beta cells, and if you can do that, you can actually start making insulin again. The problem with that is right now is you're training diabetes to become essentially a transplant patient, because you have to take immunosuppressants to prevent rejection. And if we can figure out how to do that without needing immunosuppressants, I do think that's going to be, something that would be, once
Game
again,
changer.
be a game changer.
All right, well, let's shift gears because we have a lot of other
Okay.
things I want to get to. Puberty.
Yes.
Obviously, as opposed to diabetes, this is something everyone will
Yes.
encounter, every patient. Is there good evidence that the average age of onset of puberty is getting earlier?
I think so. There
Okay.
is. I think if you look at over the last maybe decade or 2 decades, the age appears to be, kids are starting younger.
Sure, there's lots of theories, and
Yeah.
probably some of them are more than theories. What are some of these causes?
The thought is if you reach a certain weight or perhaps body mass index sooner, the body then triggers, it tells the brain, hey, we're ready to progress on into the next stage of development. We've really seen childhood obesity drive early puberty. So that's one thought. Number 2, endocrine disruptors. And these are things that perhaps may influence hormone levels. Perhaps 10 years ago, we thought it played a bigger role than it does now.
And again, just for clarification, the idea is that there are environmental toxins
Yes.
of all types, and some of these toxins are endocrine disruptors.
Correct.
So there's some asbestos and stuff that aren't.
You're right.
They're just toxins that affect other things, but then there are some that specifically start messing with the knobs.
Yes.
And that's what you mean when you say endocrine disruptors. And I think what you were saying is that previously there was more concern that these were affecting puberty.
Yes.
And maybe a little less so now.
Maybe a little less so now, because I do think that 80% of puberty, or the timing of puberty, is controlled by genetics.
Okay.
And once again, we're now starting to identify even more of these genes that control puberty. And a lot of the conditions we thought were idiopathic, well, we don't know why certain kids start puberty. Now there's a genetic cause for it.
As far as if you were telling a parent red flags for concerningly early puberty?
For girls, it's really easy to tell, because the first sign of puberty is breast development or breast budding. Boys, it's a little bit harder to tell because it has to do with testicular growth. And if you're not looking, you're not going to see it. In terms of pubic hair, body odor, that can correlate with early puberty, because usually at the same time when breast development starts, or when the boys start having testicular enlargement, you start having body odor, you start getting pubic hair, axillary hair. But you can actually start having hair and body odor much sooner. And majority of the time, it's actually a benign condition.
Are there certain ages you would say, if you're really seeing puberty prior to this,
Yeah.
you definitely should reach out to
So
someone?
for girls, it's age 8.
Yeah.
So before the age of 8,
Breast
and boys,
development
breast
before the
development
age of
before 8, correct. And boys, it's any changes before the age of 9.
Okay.
So
That
once
sounds,
again,
when we say that,
Yeah.
sounds so
It
early
does sound
to
so early.
parents.
yeah, it does. But what's really surprising is that now, especially in girls, kind of one of the hot topics in puberty now is we're noticing breast development in girls starting a little bit sooner, even sooner. But the age of menarche hasn't really changed that much. We typically refer to the timeline of progression as breast development, then it's 2 years until you get your first period. And once you hit that first period, you have 2 more years of growth. You only grow about 2 inches. So remember that the majority of growth happens for girls before menarche occurs. Now, perhaps this timeline now is being extended. So
From onset of puberty to the first period.
correct.
Okay.
Now, if you identify a girl, let's say at age 7 with breast development, we typically would say, okay, by 9, we would expect that first period to happen. But now we're starting to see perhaps that timeline is being extended. So she may not get her first period till 10. And for us, really, that's kind of the cutoff is if 10 is still early, right?
Yeah,
For
right.
the first
It does,
period.
and again, that feels very
Yeah,
early. to
but we have to have that cutoff at some point, right? So traditionally we've said, hey, if you're a girl and you can, it's not going to be until age 10 till the first period, we may be okay as long as the height's okay. So remember, growth and puberty go hand in hand. The sooner you start puberty, the sooner you finish growing. The later you start puberty, the later you finish growing, and that's why we're so concerned about early puberty too, is because it can impact your final height.
I was going to move on to obesity.
Okay.
Okay.
Sure.
So maybe one way to talk about obesity and obesity treatments is to talk about obesity treatment prior to GLP-1s, and then kind of maybe speak to how things have changed in the last few years.
Back in the days, we used to say, hey, you just got to eat less and exercise more. But now we're once again starting to understand that there are other factors potentially influencing how your body processes energy. And once again, looking at genetic studies and these looking in the genome, there are certain genes where if you have a variant, you may have sort of this genetic obesity predisposition.
And probably maybe it's worth saying there are other rare endocrine causes, thyroid and others. And we're talking about when those all tests are normal.
Yeah. And it's very rare. The majority of referrals we get for childhood obesity, weight gain, we don't find an endocrine condition. We check for thyroid. Every once in a while we'll check for Cushing's, but the majority of the time, we don't find anything. And there's an easy way, as you know, how we can figure that out is you look at the growth chart, right? If you're growing normally and you're gaining weight, then it's exogenous.
Yeah, that we were always taught that even though it's rare, if there is a red flag for endocrine-related obesity, it's short stature and obesity. Yeah,
correct.
Whereas most of the patients who I think you're referring to, their height is not impacted. It may even be a little prematurely elevated. Yeah.
Yes.
Okay.
Yeah, and for those cases, we know it's just this imbalance of calories in versus calories out. You still have to do lifestyle modifications. And for me, I usually say, eat more protein, obviously eat more veggies to be healthy. Really want to cut back on the carbs, carbs and sugar. Part of that is from the insulin response that we see when you eat high amounts of carbs, okay? Because when you eat a lot of carbs, your insulin goes up. Your insulin goes up, makes you gain even more weight, which once again causes this vicious cycle. And insulin is this hormone that wants to hang on to things. So whatever weight you have, it wants to hang on and wants to build on it, whether it's muscle, whether it's fat. And if there's family history of type 2 diabetes, insulin resistance, a lot of people have these high insulin levels and it's very, very hard to lose weight.
There's a little bit of a trend towards continuous glucose monitoring in people that do not have diabetes, right? And whether it's just insight into your own health, but also potentially in obesity.
Yeah, and it's interesting because you can see how certain foods affect your blood sugars. And if you have this high rise in blood sugars, your insulin spiking right after that to bring it down. Perhaps it allows for some behavior modification. If you're wearing a CGM, you may not choose to eat something when if you look at it, your blood sugar is gonna increase.
Yeah. I mean, I do think we all tend to respond to data, not perfectly, but somewhat, before getting into GLP-1s and things. Endocrine disruptor chemicals as it relates to obesity?
Not as much.
Okay.
Yeah. I think mostly puberty is where we've seen that topic. I'm sure there's some evidence out there or some suggestions perhaps, but on the grand scheme of things, it still once again comes to calories in, calories out. Do you have a genetic predisposition? Do you have insulin resistance?
I've heard, and this may not be completely accurate, although I think it probably is ballpark-ish, that there's been like a 700% increase in GLP-1 prescribing in pediatrics
Wow.
over the last 3 years.
Yeah, I wouldn't be surprised.
Okay.
Yeah.
So where is the current state of that, and how do you navigate that?
Yeah. So if you look at the approval in terms of age, it's age 12.
Okay. 12 and up.
12 and up, you can get a GLP-1 agonist if you have childhood obesity. And, the adults, I think once again, everything starts with looking at treatment in adults, and the adult obesity. We saw really, significant results in use of GLP-1 agonists. And what it does is it works on 3 different areas, right? First, the type 2 diabetes medication. So in the pancreas, it increases insulin secretion, decreases glucagon, so it helps with their blood sugars. But not only there, we actually saw that in the gut, it slows down gastric emptying. And that in itself contributes to you feeling more full.
Earlier, yeah.
Yeah. And then it acts at the brain. Once again, that's the satiety centers. So you feel full, you're less hungry. And that's how it helps in terms of obesity and weight. And, now in children, the tough thing in kids is there really isn't a whole lot of pharmacotherapy in terms of obesity and weight. Some of us use metformin after the age of 10. And once again, that goes back to the thought that if you have high insulin levels, it's very hard to lose weight. You're just going to gain weight because of high insulin. And now with the GLP-1 agonist, if you can get insurance to cover it, that's the toughest part, is most of the insurance will still pay only if you have type 2 diabetes.
Let's move on to short stature growth hormone treatment. A little bit similar, but a couple decades upstream. Talk a little bit about maybe growth hormone deficiency in a classic sense, and then maybe how that's expanding a little bit.
Okay. Yeah. So traditionally, growth hormone deficiency is the inability of the pituitary gland to make enough growth hormone. And when that happens, you do not grow well. So you end up having a decreased growth velocity. And when you're not growing well, you're going to really start drifting off the growth curve.
Thinking of a parent listening to this, is it more that seem to be growing well and now I'm plateauing or I'm drifting off the chart, or really never grew well?
Well, so if you look at the growth chart, there's a difference between being short and not growing well. So you can be short, you can be at the bottom of the growth chart. And if you're tracking, let's say the 3rd percentile and you're growing normally, I'm not as concerned about that.
That's not a classic growth hormone deficiency pattern.
Yeah. Mm-hmm.
Shorter than what one may expect, but following the curve.
Correct.
Okay.
Now, if you're growing normally, you don't have growth hormone deficiency in the classic sense.
Right.
Because if you're not making enough growth hormone, you're not going to grow normally.
Okay.
And, so I'm way more concerned about a kid who perhaps is at the 90th percentile and all of a sudden now it's at the 75th, now it's at the 50th percentile.
Other things that would make a parent potentially worried about growth hormone deficiency?
Most of the time it's going to be comparing the child to his or her peers, and you're going to all of a sudden notice that there's a big gap. And if you're not looking at growth charts, you'll see, okay, well, the gap is getting bigger now. Now, it depends on what age you're at. Sometimes that gap gets bigger and the child's a late bloomer, you may be okay. So we end up doing different things such as a bone age study to help us figure out, what's going on with how much time you have to grow, and helps us differentiate growth hormone deficiency versus, other normal variants of growth.
If concerned, then you move towards testing, both X-ray and some blood tests, and even more involved blood test to try to detect growth hormone deficiency, and then there's treatment to replace that. Expanding use of growth hormone so whether it be what we refer to as idiopathic short stature.
Correct.
So maybe how that has evolved.
Yeah. So idiopathic short stature, really how we got there was we know there are some kids who are short. And if you do their growth hormone testing, they make normal amounts of growth hormone, and they just happen to be off the growth chart. Once again, we're identifying a lot of new genetic causes for that. And in terms of looking at the entire genome for how many genes are there that controls growth, now we know there are thousands of genes that if you have, once again, a single variant, it could cost you perhaps, a millimeter or so. And it's the combination or aggregates of all the variants you can have. And the analogy I like to use are you have a family of, let's say, 3 brothers. They're not going to be all at the same height. One could be 6 feet tall, one could be 6'2", and then you can have one who is 5'9", and you're going to be like, well, what's going on with the 5'9" individual? It could be these genetic variants. It could be the timing of puberty. So there is a range.
We would refer to that as long as they trended well, that's
Yes.
all within a realm of what we consider normal.
Correct.
As opposed to abnormal. And that would probably be true even if there were genetic identified
Correct.
contributors still, which I guess is one of the hard things as far as defining of normal and abnormal.
Yeah.
Right. And this is true with GLP-1s. It's true in maybe in psychiatric medicines, this tension that is not unique to your field. It's in our field too, but between treating a true disease state and health enhancement.
Yes.
And that thing on a continuum.
Right.
I know because, we both encounter this, a lot of understandable societal pressure, and
Yes.
for lack of a better term, about height.
Yeah.
How, as an endocrinologist, when there is this treatment that would make a difference, might be
Right.
quite an expensive difference.
Correct.
How do you navigate that, or how do you wrestle with that tension with parents?
Yeah. So obviously the pressure, especially for boys who want to get taller for perhaps sports or certain
Right.
things like that. We get the consults. We'll see you in the office. We do the hand x-ray. So remember, the hand x-ray and Tanner staging, I can give a final height projection that is fairly accurate. You may not be happy with the height projection, but so let's say if it's shorter than where you would like, what are the options for a boy? Number one, if the boy has started puberty yet, what we've been offering is use of aromatase inhibitors.
Mm-hmm.
And these are pills that doesn't make you grow taller like growth hormone. It potentially allows you to grow a little bit longer.
Lets the growth plate stay open longer.
Exactly.
Puberty, the puberty window stays open more.
Yeah. So as long as your growth plates remain open, the thought is that you're going to continue growing. So we can impact your final height by letting you grow a little bit longer. So that's option number one. And once again, you have to realize that it's not an FDA approved indication for use of an aromatase inhibitor, and we're using it off label. The second option is, well, can we use growth hormone? And here is where, if you look at the FDA approved indications, you have to have growth hormone deficiency, idiopathic short stature. There's other genetic conditions where you would qualify to get growth hormone, at least covered by insurance. Now, if you don't have these indications, insurance they're not going to cover it because the treatment is very expensive. Now, what I tend to do is if there is interest in enhancing with growth hormone, I will draw IGF-1 level. I'm going to look at the endogenous production. If, let's say, normal levels are between here and here, if you're already at the top, there's really no benefit to giving extra growth hormone. But if you're somewhere, let's say, below the mean,
perhaps still in normal range,
perhaps in normal range,
half, yeah.
and if there's room there, the thought is that perhaps we can increase that safely. Once again, you want to keep things in the normal range because I would say safety first, and then if we can do it safely, then there's a way perhaps of increasing. Now, remember that we don't really have anything that's going to increase 3, 4, 5, 6 inches, right? But perhaps a couple inches may be possible.
Do you have any idea on the gender breakdown, male, female, of growth hormone treatments?
It's going to be very male dominated. Okay. Because I do think societal expectations for boys and boys want to be taller. A lot of times I have girls that come in, I tell them, well, you're going to be 4'11", 5 feet tall, and they're okay with that.
Maybe a quick few questions on bone health from Any thoughts or kind of really tried and true recommendations as far as adolescent bone
Yeah.
health,
So,
pediatric bone health?
the lay population, we all think of bone health or, what makes bone strong, calcium, vitamin D. And that's true because if you look at how bone is formed, it's actually calcium and phosphate combination, and it has to get into bone, and that's how your bones get strong. Calcium is only half the equation there. Phosphate is the other equation. Now, the issue is our diet is very high in phosphate. And you can ask the nephrologist, they'll be like, it's very hard to get patients to do a low phos diet. And that's why our focus has always been on making sure you get enough calcium. Vitamin D is important because it allows your gut to absorb calcium and phosphate. And if you have very low vitamin D levels, you can take as much calcium, phosphate in the diet, and it's not going to get absorbed. So that's the importance of vitamin D. And in terms of, once again, growth, if you're looking at growth and height, you want that calcium phosphate to get into bones, and you want that calcium and phosphate actually to act in the growth plates because that's what helps you grow.
The trend lines of calcium intake have really been declining
Yeah.
in decades. And maybe I'm setting you up, but I mean, as an endocrinologist, would you speak strongly about the importance of dietary calcium intake?
Yeah, very,
Okay.
very important.
Yeah.
And
And not
I didn't
exclusively milk, but I mean, we're
correct.
largely talking about
And
milk.
I didn't realize this, but you actually have to go out of your way to make sure that you get enough calcium in your diet. I used to think, if you eat a well-balanced diet, but then again, I think you really have to see what's being consumed and make that effort to get enough calcium.
Anything you would say about where things currently stand with gender identity and gender dysphoria medical treatment?
Yeah. So obviously political, depending on what state you live in.
Right.
But, the concept of treatment of, let's say, gender dysphoria is actually not that hard because you're just shutting down the pubertal progression. And then you're giving really replacement hormone. So that part of it is fairly easy, but the entire decision is very complicated.
Right.
And I think that's where you have the entire, team and not just a endocrinologist or someone who can do those medications.
And in some ways the discussion appropriately is existing far outside of just
far
the medical
outside
world,
the
right?
medical world. Yeah.
I know there was a big cast review in England that caused a lot of conversation. I mean, is there any sort, and maybe there really isn't, maybe it's just the discussion needs to keep happening. As an endocrinologist, is there you guys, thinking of y'all's advisory body, you're really part of the AAP, but you have a section on endocrinology. There's not a separate pediatric endocrinology. It's just a section of the AAP, right?
Yeah, I believe so. Well, there is the Pediatric Endocrine Society. I thought it was part of the AAP, but it may be separate
Its
now.
own thing.
Yeah, maybe. Yeah, I think it's its own thing now.
Are there policy statements, or is it just this spirit of let's continue?
Yeah,
discussion?
it's that
Okay.
because I think these days, especially trying to get a uniform consensus
Right.
is going to be very difficult.
Yeah.
Because you're going to have just different thoughts on the matter.
Right. Yeah.
But really, like I said, it's not a medical decision because that's an easy thing
The what
to do.
to do.
It's just
whether.
It's whether to do it, and who's going to be involved in making that decision. I think is the complicated part.
Yeah, and to state the obvious, all are in agreement about appropriate supportive services as it relates to mental health and appropriately trained mental health. The questions that you're raising, which really exist more in a specialty world, really as it relates to medicines, hormones, and then surgeries.
Correct.
That's where.
Yes.
You are a pediatric endocrinologist, lots of experience, but you're also a parent.
Yes.
How do you, any personal ways you try to navigate the idea that there are potential toxins in what we breathe, what we eat, what we put on ourselves?
I don't know if you can avoid it. Yeah. So I've kind of come to that conclusion there's only so much you can do. And I know some people may take more of an active role into, okay, we're not going to use plastics, et cetera. But, I think these days now, there's certain things you just can't avoid, right?
So as an endocrinologist,
Yeah.
there's not evidence that's about a particular one that's conclusive enough that you would say you definitely should
Correct.
this or that. Okay.
Yeah.
AI in your field. I mean, I even think about like the reading of
Yes. So there are programs out there that allow for these automated readings of bone ages. And, my thought is, hey, it does allow for some uniformity there. As long as the bone age reading it looks good, but you may miss certain markers that can identify perhaps a genetic disease or something. So it's not quite there yet, but from a bone age reading, it actually serves its purpose. And I know some places have gone to that now to kind of get the uniform.
AI, because
Yeah.
right now it depends on the just clinical acumen of the individual radiologist
Correct.
or endocrinologist.
And as there's varied interpretations and readings and different methods that we use to read bone ages.
Anything else AI you see penetrating your field?
From a patient care standpoint,
Not yet.
not yet. Besides, I would say the technology we have with our pumps and CGMs. So that's very AI-ish. Once again, if you can have your pump and CGM talk to each other, take the decision-making process away from, the individual, to me, that's AI, right? So there's now an insulin pump where you don't put any settings in. You just put the patient's weight in. It's called the islet pump or islet bionic pancreas. And traditionally, every time you eat, you have to enter how many carbs, right? So the pump can deliver that right amount of insulin. So this pump, what you do is you just tell the pump whether you're eating a normal meal, small meal, or a large meal, and it figures it out by itself. And your patterns of eating may change, and it adapts to that. So I think that's an example of AI in diabetes management.
Well, and certainly a place that it will continue to improve. It'll continue to be able to improve. What motivates you on a day-to-day basis? I mean, there's some commonalities and some transcendent things that will probably motivate all of us, but you uniquely, if what is it that motivates you?
For me, we do a lot of growth. We see a lot of kids that come in and aren't growing well, and they grow. So I think to me that's a personal satisfaction, and they come in. These kids want to grow. So at least from that standpoint, in terms of our growth patients, it is very satisfying because you can see the effects of them taking their injections. They're no longer the shortest kids, in class. To me, that's a personal satisfaction there. And of course, I've been doing this so long, and you too is you see the patients and their families, and part of that is a lot of endocrinologists actually do research. If you're at a big academic center, you're primarily doing research and not seeing as many patients, but I do enjoy that aspect of it.
Anything else about the future of pediatric endocrinology? Like if you and I were having this conversation a decade from now, you already alluded to some of that. Anything else you would look into the future and potentially see?
Yeah. So I think we're always looking for, let's say, better treatment. And so growth hormone, for example, when I started daily injections, now we have weekly injections. And I foresee perhaps, injections, monthly injections. So things like that will become easier for the patients to administer. I see that. Even when we talk about puberty, your central precocious puberty, the treatment center when I first started was a monthly injection. It's now a 6-month injection. So longer acting medications, especially hormones, would really make sense. And in terms of certain I think we'll find out a lot more genetic causes, a lot of these things that are idiopathic at this time.
You get concerned, I'm thinking of you as a section chief. Do you get concerned about a potential shortage of pediatric specialists?
Yes.
You do?
Yeah. And especially in our field, I know the last couple of years, only half the fellowship positions are filling. We aren't getting a lot of people graduating and entering at least the pediatric endocrine workforce. And we are seeing some of our older colleagues retire at this time. So yeah, I think that's going to be an issue.
Any ways that it's actively being addressed? Any recruiting strategies?
I think we're going to really have to encourage our, med students and residents to consider pediatric subspecialties. It is an additional 3 years of training on top of your residency. I know some people have looked at, could you shorten that amount of time? But I think, something has to be done to either attract more candidates or make it a little bit easier to access.
Yeah. I mean, I know one of the things, I haven't heard this specifically in endocrinology, but so much of the fellowships have a significant research
Yes.
component. And so could you have more of a clinical track that wasn't a full 3 years?
Yeah.
If that was a discouraging factor. Yeah. I mean, it does feel like one of these things that probably isn't, it isn't, I bet most non-medical people aren't aware that there's a number of fields that really have significant shortages. All right. Well, why don't we move on to rapid fire
All
questions?
right, let's do it.
Okay. So again, you just have to tell me your quickest answer.
Okay.
All right. Beach or mountains?
Beach.
All right. Disney, Universal, or Gatorland?
Disney.
Okay. Yeah, but you have a young child.
Yes.
Apple Music or Spotify?
You know what? I've never used Spotify. So
Okay.
I have Apple Music, but now I've actually started using YouTube Music.
Okay.
Yeah.
All right. Speaking of music, if the faculty at Arnold Palmer Hospital had a karaoke contest,
Yes.
who would be your biggest competition?
Oh, my biggest competition. Oh, wow.
Because I've heard you are an outstanding karaoke performer.
Well, I only have a few go-to songs.
Okay, which are?
Pour Some Sugar on Me.
Okay. Is that Def Leppard?
Def Leppard.
Yeah. Okay, that's your go-to?
That's probably my go-to.
All right.
Yeah.
Well, it made quite an impression on some people because, so you don't feel like there is any competition?
I don't know. There may not be. Gene Chen.
Oh, you think?
Perhaps.
Okay.
Yeah. Maybe I'll get him out there.
You need to do that. What would be your career if you weren't a pediatric endocrinologist and money was no object?
I think I would be a CSI.
Ah,
I love the show.
nice.
And I'm trying to figure out, what's going on. And so I've always, been interested in that.
That's cool.
Yeah.
Last question, if there was a genie of pediatrics and you had one wish for one thing you could wish for that would happen in the world of kids' health, what would it be?
I would say to prevent childhood obesity. I'm kind of, selfish in that sense,
Yeah.
but, healthy, just lifestyle, for kids to be able to just be more active.
Yeah. Yeah, that's definitely an issue. We're going to have a future episode just on the importance of play and things like that. Cause it is, again, it's a perfect example of one of these things that is such a part of pediatric health that just because it's not an acute condition, it just doesn't get talked about enough in pragmatic ways. Well, you have cared for so many of our patients for so long. We, the concept of a medical home. We feel like we are being a medical home for our families. And so therefore, one of the implications of that, we feel like every referral we do is really an extension of a relationship we have with that family. When we refer patients to you, it is with the highest level of confidence that they're going to get great care. So Dr. Yang, thank you so much for caring well. No, great
Thank
gift
you
for
for
our
having
community.
me.
Yeah, absolutely.
Yeah.
Great stuff.